So we're really excited to be here in this 50-minute session. You're going to hear from 8 clinical faculty from the Ernest Marius School of Pharmacy who are preceptors of students in our ambulatory care clinics throughout the state of New Jersey. And if we could just introduce each other in alphabetical order. First, I'm Mary Wagner, the last on the list, and I'm a associate professor in the School of Pharmacy in a variety of AmCare clinics. Okay, Tom.
Hello, everyone. My name is Tom Bateman. I'm a clinical assistant professor. I practice at Austin Health Center, a federally qualified health center in Trenton, New Jersey. I work in an interdisciplinary team to manage patients with chronic conditions.
Hi, everyone. My name is Christine Dimakulanga, and I'm also a clinical assistant professor. I'm at the School of Pharmacy, and my clinical practice site is at the Center for Comprehensive Care in Jersey City, New Jersey.
Hi, everyone. I'm Caitlin McCarthy. I'm also a clinical assistant professor at the Ernest Marius School of Pharmacy, and I practice at the same location as Dr. Bateman, Henry J. Austin Health Center in Trenton, New Jersey.
Hi, everyone. I'm Amy Patel. I'm also a clinical assistant professor at the School of Pharmacy at Rutgers University, and my clinical practice site is with Robert Wood Johnson Barnabas Health, and I have interdisciplinary clinics, and I manage chronic disease states.
Hi, everyone. I'm Lucio Volino. I'm a clinical associate professor and the director of assessment at the School of Pharmacy. My practice site is with Barnabas Health Pharmacies, and I'm based out of the RWJ Barnabas St. Barnabas Health System in Livingston, New Jersey.
Hello, everyone. My name is Sarah Weinstein. I am a clinical assistant professor, and similarly to others, I care for patients through interdisciplinary workings in Flemington, New Jersey at Hunterdon Medical Center.
And lastly, I'm Mary Wagner, and my clinical site is at a federally qualified health center up in Newark, a nurse-managed clinic that manages chronic disease states as well as HIV. And I'm in a geriatric clinic, a family medicine clinic as well in Monroe, and the epilepsy clinic at Robert Wood Johnson University Hospital. And we're excited to start with our next slide that goes over our goals and objectives for today. We could move forward. So today, what we'd like to do is explain to you what an ambulatory care pharmacist is, and tell you a little bit about the different technologies we use for virtual learning. We had relatively a couple of weeks to transition our students from live, interactive, interprofessional practice experiences with patients and other students and attendings to a virtual experience. Many of the clinics had shut down completely or were for quite a long period of time. Some quickly transitioned to virtual patient care. So each of us had a variety of different experiences, and we worked collaboratively to build a curriculum that we felt would identify all of the needs that we had to develop a well-trained clinical ambulatory care pharmacist that met the standards of our curriculum. And we used a variety of technologies that are used in learning as well as patient care to accomplish this. And so we hope that you'll be able to list various pros and cons of the various virtual learning techniques that we used and utilized, and that you'll be able to work in small breakout sessions. 2 of the faculty will be working together in 4 different breakout rooms where we will work with you and share ideas to help you improve your curriculum.
So to get started, I think we all need to know a little bit about what pharmaceutical care is and to help set up what an ambulatory care pharmacist does. So really, when we think about pharmaceutical care, it's looking at how medications and therapies help patients achieve their goal and become better and improve their health through specific outcomes. And the outcomes themselves can range anywhere from curing a disease to preventing that disease and somewhere in between. So quite often we may need to manage conditions or help a person feel better by necessarily curing the disease, or we might need to delay the progression of the disease. So the decisions that pharmacists make are really integrated into an interprofessional health system. And this usually happens either in an inpatient setting or in an outpatient setting. And an ambulatory care pharmacist will be spending their time in the outpatient setting, in that ambulatory setting, where people can move around, go from doctor's offices to pharmacies to clinics, whereas an inpatient would be stuck within the hospital system itself. Next slide. So some examples of an ambulatory care setting could include something like an ER, where a patient may visit and then be able to leave, or going to their doctor's offices and then going to a pharmacy to pick up their medications, or working with many of the pharmacists you'll talk to today with their ambulatory care clinics or outpatient clinics. Individuals here will go to a center or a clinic and they will interact with the pharmacist, where they can review the medications, look over their medication profile, and truly get an understanding of the patient's behaviors to make change. So working with other healthcare providers, there will be interventions that are made to help them understand what they can do to improve their medication use, potentially prevent future conditions from happening, and managing the current ones that they do have. Next slide. So the goal here is to shift the care from the inpatient side to the ambulatory care side, or the outpatient side. And by doing that, we can not only make it more convenient for patients, but also save a considerable amount of money that would be spent towards healthcare for the patient as well as the healthcare system overall. So we found that if we can interact with patients in the community setting, we can make interventions, prevent them from getting admitted when those situations happen where it could be really severe. So if we can work with patients to do screenings in the outpatient setting, then that'll prevent an admission to the hospital for, let's say, a heart attack or a stroke. So we can identify those opportunities to educate patients, to work with them, to change their therapy, to prevent those really severe and tragic things from happening, and then while managing all of their care. And this is a picture of a pharmacy where I'm at St. Barnabas Medical Center. We have 7 retail pharmacies that are situated in the health system across New Jersey, and 2 of them are in ambulatory care centers. So although this pharmacy looks small, we do quite a bit to work with the inpatient side to make sure that patients leave the hospital knowing their medications and they don't come back. Next slide. So some examples of what an ambulatory care pharmacist does are listed here. And you can see it's everything from making sure that they're on the right medications, they're taking the right dose, that they're actually taking their medications, that we ensure that we maximize those therapies and prevent some of those side effects or potential problems that could happen. Many of our pharmacists work within clinics and specialized clinics such as Coumadin clinics, where we can monitor patients' therapies, monitor their lab results, and make interventions. That way the person doesn't have to go to a hospital to be evaluated. For example, for a Coumadin clinic, we're looking to make sure that their blood is thin, but not thin enough where they're going to bleed out. So we want to make sure that within a targeted area, and pharmacists are working with patients to adjust those therapies to make sure they're in that sweet spot for their medications. And eventually, we're trying to prevent people from going to the hospital, which is going to require testing. So we'll do blood pressure screenings, blood glucose, cholesterol. We can test for sexually transmitted infections. A variety of different tests can be done to minimize the impact of somebody having to go into the hospital or getting to the point where they need to go to the hospital. So all of these interventions, including immunizations, which is a big topic right now, are intended to prevent diseases from happening. And that's where we, as somebody in the community, can help individuals manage their own care and work with other healthcare providers. So we leave notes, we work with other healthcare professionals to make sure that we can give them recommendations, work together to pick out the right therapies. So it's truly an interprofessional experience. And this is where our students spend their time during their last year of pharmacy school. So as you can see, with a pandemic where things are virtual, it could be really problematic, and it could be troubling if you don't have access to patients and resources and all these activities. So it's tough to do a blood pressure screening over a computer. So we designed some activities to make it more interactive, to really bring in the patient care, so students got those experiences without having to be in person, and we could adapt along the way. So we're going to go through some of those topics today, and I'm going to hand it off to Dr. DiMcLennan, who's going to talk about what we did and how we did that through the past year.
Lucio. So as Dr. Volino had alluded to, during the pandemic, I'm sure with everyone here on this conference call, the world turned upside down for everyone, as in terms of teaching, in terms of interacting with our students, our patients, the rest of our staff at the clinic as well. So I'm going to go into a little bit what that timeline looked like for us a little bit over a year ago. So next slide, please. So students prior to the pandemic, as Dr. Valino had alluded to before, were able to see patients in person, make those interventions to physicians within the clinic. They were able to attend rounds. They were able to do all of these things working within the interprofessional team as their last year as a pharmacy student. So a lot of it was interacting closely with the team, with the patients, with other students on the rotations as well, other students of other professions. And then when things kind of flipped the switch, everything went virtual. So that included telemedicine appointments, seeing patients through a computer, or discussing these medication interventions through the telephone. A lot of the meetings or other ground rounds were done during Zoom calls, WebEx meetings, and essentially, a last year of rotations where you're interacting with people in person live ultimately became something where no one was really seeing anyone in person and everyone was seeing everyone through a screen. And if we could go to the next slide, I'll go into what that timeline exactly looked like. So a little bit over a year ago, which is very difficult to believe at this time, it was spring break for our students, and it was our time as faculty to kind of brainstorm and figure out in a quick turnaround time how we were going to deliver these live patient care experiences virtually through the computer, through these webcamming interventions. And it was quite difficult because a lot of us didn't really have this experience with telemedicine, with virtual calls. Everyone was new to this, which I'm sure a lot of you were as well. So we had these weekly meetings where we were speaking to the experiential team, who also was in charge with taking care of these students and making sure that they were having a robust patient care experience without being on site live or in person. These meetings were our way of kind of sharing some of the ideas, where we were able to collaborate with other people of the same discipline. So the professors here on this call were all in the outpatient or ambulatory care setting, whereas some of the other settings were critical care, oncology, infectious diseases, and of the like. By the end of March, every student, if they were on a rotation, were basically in the virtual format. There were certain activities that were done, certain lectures, certain presentations that were done in tandem with other faculty members to be able to bring these robust experiences to life. Certainly within the past year, that solely virtual rotation experience turned into a hybrid where, for example, my students, half of the time are in person, live, of course, with masks and social distancing as much as we can. And then the other half is collaborating still with other students in the same discipline, doing literature reviews, topic discussions, and other activities that we'll go into more in detail later on in the presentation. And then talking about present day, those weekly meetings turned into maybe once every other week, still idea sharing, but really evolving into how we can make these experiences more optimized and more better for our students so they're able to go out into the real world after their last year of pharmacy school, still with that robust like experience that they would have had pre the COVID pandemic. Next slide, please. One of those things that we had incorporated and really was a staple to our virtual or hybrid rotation was the creation of the ambulatory care elective. And from there, we mirrored some of those activities such as literature reviews and incorporating a patient case that evolved week to week in this 5-week rotation based off of the topic discussions that were assigned for that week. So for example, in the first week, we might have done a lot of healthcare maintenance topics, immunizations, and in turn, the case for that week that the patient or the student was going to interact with that patient with really had to focus on healthcare maintenance and immunizations and vaccinations. So certainly this was the skeleton with which we built a lot of our rotation experiences on, allowing our students to still get the activities that were encircled with literature reviews, topic discussions that involved ambulatory care experiences, and also still getting a taste of patient care experiences through this virtual case. Next slide, please. And then now we're going to really kind of delve into some of those specific virtual technologies or platforms that we use. And if we go to the next slide, we start off with the Canvas site. So some of you may or may not be familiar with Canvas. It's really our central hub of where we put all of our schedule, the syllabus, some of the modules, the different groups that were assigned through the different rotations, when they were going to present. And it really was a user-friendly site for us to use, because not only was it easy for all the students and the faculty members to kind of go and see what they were assigned to, but it was also easy to manipulate throughout the different rotations, because this was certainly not something that was kind of stationary throughout the year of the pandemic. Certainly, there were a lot of changes that were made even after the first 5-week rotation. So it was easy to manipulate, it was easy to change, it was easy to present or not present some of the concepts that we had for the students. And as you can imagine, at a 5-week turnaround time, it's important to have a platform that's easily malleable and that could easily change with the times that were happening in real life. So after that, I'll pass the baton over to Tom, who will talk more about some of the virtual learning activities that we had for our students as it pertains to patient care.
Thank you, Christine. So I'm going to speak a little bit about EHR Go. And so EHR Go is a simulated electronic health record. And essentially, clinical pharmacists and other healthcare workers in our daily practice use an electronic health record when we're managing patients. These EHRs give us an opportunity to document notes about our interventions and recommendations. And so with EHR Go, this is a similar platform. It's a simulated platform where we can actually create our own patients, and then that way students can manage the patients. So students gain clinical experience by reviewing patient data within EHR Go, by administering medications, and they can also write clinical notes. The advantage here for faculty is that we can filter and search for available existing cases. So you can filter by patient age or practice setting. So we were able to find cases that were relevant for ambulatory care. We can assign cases from a library of available patient cases, or if we wanted to tweak or edit an available case, we could do that or create our own from scratch. And you can attach resources to patient cases. So if we wanted to have a diabetes case, we could attach literature related to diabetes that students could then utilize when working up that patient in the EHR Go. And finally, we could share editing capabilities for the same patient case so that multiple faculty could edit that same patient case. Next slide, please. So EHR Go is especially helpful because it can be used all throughout the student's academic experience. So EHR Go is utilized in didactic classes, and this is an opportunity for students to apply the information that they're learning in class. And then also with the onset of COVID-19, we had certain students who were not able to go on to their rotations. They weren't able to actually go onto their practice site with their faculty member. And therefore, they were losing out on patient care opportunities. So EHR Go could be a solution for these students who can't go on site, but they can still work up patients in the EHR Go platform. So Rutgers facilitated this by approving EHR Go licensure for all of the P4 pharmacy students, and those are the students in their final year of schooling. And we use the EHR Go platform in our hybrid ambulatory care rotation over the course of 5-week rotations. So during the orientation period on day 1 of the rotation, all of the faculty would meet along with all of their respective students, and we would define what the expectations were. And then we were able to assign a singular patient case that faculty could then update on a weekly basis, and students would work on independently. And I'll turn it over from here.
Hi, next slide, please. Thank you, Tom. So similar to EHR Go, we had another strategy of almost like a resource where we had pre-prepared learning activities from CORE Readiness. This was another resource that was provided by Rutgers where we didn't really need to reinvent the wheel and come up with teaching and short courses of concepts that students were expected to learn and apply during their final year in pharmacy school. So these topics were both clinical, but also counseling and other strategies that they live rotation. So it was meant to sort of mimic some of those topics. And at the end of each of the mini clips, the students were also assessed on their understanding of each of the concepts, and they were provided with a certificate. So this was one of the resources that we used that were a little bit more hands-off. The videos were pre-selected by the group, and they were what applied to an ambulatory care outpatient setting. Next slide, please. So other than patient interaction, a lot of our challenges during the pandemic arose from communication with the students, with the patients, and with each other. So some of the ways that we overcame that were using WebEx, which have been used in a lot of different arenas. In terms of the teaching setting, we've used WebEx for a lot of participants. We can use it for up to 1,000 people who can fully participate in the WebEx. The WebEx service that we use through Rutgers is HIPAA compliant, so we can share patient data and talk about patients through the service. We can also record the meetings if we were teaching a topic discussion, for example. And the host of the meeting has the option to mute participants, which I've actually used that function several times in the past couple of weeks, where some of the attendees inadvertently would be, discussing the topic offline, and I would have to mute the participants. So it's a nice option. And some of the strategies that we use to keep the room secure would be to schedule the meeting rather than using just the personal meeting room. And having a scheduled meeting allows for only people who are invited or provided with that specific link to have access to the room, and therefore we can discuss patient information more securely. And then in terms of how we can invite participants, it's through a URL, and there's no download needed if you're using it on, actually there isn't downloading, excuse me. We do need to download if you're using it on an app on a phone, and similar to that on the computer. And on the next slide, I'll go over Zoom, which is very similar. We can use this again for patient use. So it's HIPAA compliant. We can discuss patients over this. The reason why we used WebEx and Zoom for a majority of our sessions were for topic discussions and those large literature reviews, where students from each of the different faculty participated with each other. This was something that they would normally do live prior to the pandemic, but because of their the hybrid setting, we had this service in order for them to interact with each other, practice their presentation skills, and also topic discussions, and be able to communicate without having that live experience taken away from them. Other options that we can use in Zoom with live teaching are Whiteboard, which allows us to draw on the shared screen. Similar to that, we have the annotate function, which allows you to write on a blank screen. So kind of giving that live lecturing experience if we're doing a short topic within the session. And then something that we'll experience at the end of our 50-minute session today will be the breakout rooms. So we have a function like that on Zoom as well, where we can separate participants to allow for smaller group discussions, which helped us to allow for more audience participation rather than a large group setting where usually participants are rather silent. So I'll move it, actually I have one more slide for interactive teaching. So this was, these were some of the tools that we use in order to engage our students. So within the topic discussions, rather than keeping the topics just lecture-based, we also created questions that would kind of mimic what they would be asked in a live topic discussion, and also some questions that helped prepare the students for board exams that they would see at the end of pharmacy school. Some of the functions that we used were Jeopardy, where the screen would project a Jeopardy type board, and students were able to participate in teams, select questions, and answer the questions. Kahoot was another game resource that we used, where students can actually log in using their mobile device, so very 2021 friendly. And students were able to select the correct answer and participate. And this was either using teams or individual players. And then Poll Everywhere, as you may or may not have used, is another function that we can use to assess students' knowledge of the information that we're sharing via the topic discussion. And we can go into each of these in more detail in the breakout session if anyone's interested. So I'll pass it over to Anid.
Yes, hi everybody. I didn't introduce myself before. My name is Enid Morales, and I'm faculty and clinical pharmacist at Eric B. Chandler Health Center, which is a community health centers, a federally funded health centers that provide hair care, primary care to underserved patients. And as you can see from the slide, is actually part of Rutgers University of Rutgers Medical School. And the platform that the university provided all the healthcare providers was to provide telemedicine was Doxy.me. So as a healthcare provider, that was the platform that I was able to provide healthcare for my patients, which very important, obviously, is HIPAA, meet HIPAA requirements. Very also important is anonymous. The program doesn't save any patient health information, and pretty much every information about the patient is actually destroyed at the end of the call. Is also very important for my population, as I said, underserved patient, because it doesn't require the patient to download any software. So it's very simple to use in that respect with the patient. Obviously, the type of platform that I was offered as faculty with the medical school or with the Eric B. Chandler Health Center was a professional package. So I have read that, although I don't have experience with the free Doxy.me, it actually even allows the providers to personalize their site. As you can see, our site is personalized with the Rutgers logo. But the professional program that I have actually allow me to share my screen, and also very important in terms of providing a virtual rotation, it allows me for group calling. So next slide, please. You can see here, when we talk about not needing to download a program, the best way for me to actually reach my patients is actually to text my patient. Many of the population that we serve do not have computers or do not have email, so it's much easier for me to text the patient and actually invite them to the room. So on the top, you can see the text function, and then you can see on the bottom left the text that the patient received, indicating that the provider is asking to come to the appointment through a secure website. Once the patient writes their name, allows the use of the microphone and the camera, which I have to say is a problem for many of my patients. They have their camera blocked, and I have to guide them through that. Then they actually wait in a waiting room, and I have the ability to then let the patient in, so no other patient can come in at the time that I may have another patient. Also very important here is that at that point, I can ask the patient for permission to get my students into the call. So once the patients allow me or to have the student into the call, unfortunately, I have to text the patient and they log into the URL, my personalized URL, and then they can cancel patients and also interview patients to provide healthcare. The next slide, please. Next slide. Okay. So here you can see when I'm with the patient, obviously I don't have a patient in this picture at the bottom left. I can look at the patient chart and write my comments as I'm providing care. What is interesting that you can see on the right side is that I actually can provide live education. So I would ask, for example, the patient's values when I'm explaining their disease, and they are able either to video screen the conversation, or they could also screenshot it, which is also very helpful to have. And the students, again, will be able to educate the patients using this platform. So it allows for the student for patient counseling. And then next slides, in terms of the advantage and disadvantage, obviously is very helpful that, particularly for my population, that I can access them through text. However, as you would imagine, they're not necessarily computer savvy, which I don't blame them. I'm not either. And so very often I have to call them first and go through the process until I'm able to log them in. So as you would imagine, that's time consuming. Also, it requires me to text the student. And of course, sometimes they take a little time to join in. But And also sometimes because the patient internet connection might not be very strong, sometimes with a group call, you may lose the patient. I only had pretty much in a year using this one patient that had declined because of limited data plans. So pretty much is very helpful in programs to provide healthcare and a wheelchair rotation at the same time. Next presenter.
All right. Hi, everyone. So I know that we're running low on time, so I will be brief. So next, I wanted to quickly go over our assessment and our grading for our virtual rotation. So fortunately, we didn't need to make too many large changes to how we assess our patients or how we assess our student learners. So one of the key things that we did was we did create a uniform literature review rubric, since that became a big part of what we did on our virtual rotations. And again, as we mentioned, when we were creating the rotation, it was important for us to not have to recreate the wheel. So we utilized the same literature review rubric that we utilized in the ambulatory care elective, and then simply adapted that so that it would be appropriate for this rotation. And again, to try to decrease the amount of work that everyone needed to do for the specific presentations, we had 2 faculty members who were each assigned to be the facilitators. So the 2 faculty members would break up the work and would each be responsible for putting together the rubric for one of those presentations. There are also some faculty-specific rubrics that were created depending on the specifics of the rotation, because some of the faculty member would have other requirements, such as patient cases and seminar presentations, but a lot of those rubrics were already created by Rutgers and through our department, so we could adapt those as needed. And then finally, we did overall rotation grades. Now, there is really no change here because this was already within the Core Elms electronic platform. So this was nice because everything was already set up in this way, so we didn't need to make a lot of changes. Students were already comfortable with this platform from being on their introductory practice rotations, and faculty were also comfortable with the platform as well. So we had formal, midpoint, and final assessments with our students. This was created based on a rubric that was provided from the experiential committee. However, you as faculty are able to reach out to experiential to make adjustments to the criteria or to change the proportion that each criteria goes towards your end. And then we also had some that were completed by students themselves. This was really helpful for us as we adapted our rotation. So students would do peer evaluations, which helped them to engage. Time logs. So at the end of each week, students would submit time logs, letting us know how much time was spent on each activity, and then also satisfaction with the activities. So this gave us assessments as to how students were learning and then how we could adapt moving forward. So next slide, please. So the piece that I'll spend a little bit more time on is the barriers to virtual learning environments and how we kind of went through to overcome these barriers. So as to be expected, anytime there's a new learning platform, there's going to be challenges that we had to overcome. So we had to be welcome to communication from students and feeling like we can be adaptable in this setting. So some of the challenges were engaging in large groups and assessment of students' understanding. So I would encourage you, whatever platform you agree to use, really understanding in depth that platform and the students and the utilization to its fullest capacity, trying to offer different ways of communication and more opportunities for formative assessments throughout your presentation. So things like poll questions via Zoom applications and breakout rooms, giving the student the opportunity to use the chat box function instead of needing to verbally respond to questions, and incorporating games. Another thing that can be really helpful is setting the standard for students to prepare to ask questions during the assessment and to complete peer assessments afterwards to ensure engagement. And then, of course, debriefing with their primary preceptor. We did have to recreate the wheel for students who had already participated in course or previous rotations. So we had to think about, what do we do when we have students who have already done the rotation? So maybe that's being more creative in how we utilize those students in the rotation. So instead of doing the same presentations over and over again, having the students work with the primary preceptor to help facilitate those rooms. We had to update certain technologies on a regular basis. So the EHR Go case, we did have to designate one person to continuously update that. So being mindful of the amount of time that it takes and the amount of faculty effort and making sure that that's equally distributed amongst all of the preceptors. As mentioned before, some of our students in this kind of virtual setting took more of a backseat role instead of a proactive role, which can be very common when students are not physically within their teams. So making sure that students are introduced to their team members and trying to incorporate them as much as possible with patient care. So in the virtual world, if we're getting, say, a topic discussion or a drug information question from our primary care providers, even if we could easily answer that question right away ourselves, involving our student learners in that discussion so they feel more comfortable knowing the types of interventions that they can make. Time management is always a challenge on rotations, regardless of whether it's in person or virtual. Having those time logs was really helpful because we were able to help guide the students if we noticed that they seem to be spending a lot of time on one area, which is really something that we wanted less focus on and kind of redirecting their time. Making sure that students have expectations ahead of time and trying to carve out that one-on-one time with students as much as possible. So for us, something that could be helpful is scheduling a once weekly meeting with students where you don't have anything scheduled, no agenda, just kind of that touch base. And then also the last thing is really that COVID impact. Now, of course, I think a lot of us know that COVID has made a significant impact on our rotations, but one thing that came up a lot were things like time away from rotation because of self-care or care for others. So students had to do weekly COVID testing, or perhaps they had to take care of other people in the home. There might be other duties. So I know that many of our faculty and many of our students don't have separate offices at home where they can sit and have that protected space. So thinking about professionalism in that virtual environment. So if you're giving a presentation from your bedroom, things that we would never think of before, like did that student make their bed before the presentation? Do they have distracting posters? Or if they're screen sharing, are they sharing the correct screen and not say their Facebook live stream, which can come up sometimes. So it's really important that you set the stage for right at the beginning of the rotation, what are the requirements for professionalism? And making sure that students feel very listened to. So making sure that you do present yourself as a preceptor there, someone to support them and help them through the pandemic. And then I will turn it over to Sarah for the final slide.
Okay, thank you for that. So as we have progressed throughout the year, our rotation has significantly changed. And so the virtual rotation format has really evolved as we've become more comfortable with virtual setting, and that our students have also become more comfortable. And so with each start of the rotation, feedback from previous student rotation is discussed. So as previously discussed by my fellow presenters, we obtained informal feedback through these time logs, but also formal midpoint and end of rotation feedback. And we all came together at the start and previously to the start of each new rotation to really discuss the benefit of the different learning activities and if adjustments need to be made. And this was extremely helpful because we got to hear feedback from students on what activities they thought were most beneficial and change the rotation. So it was really a continuous evolution. And so we'd implement change, we'd evaluate those changes, whether it be on a weekly basis, through a midpoint evaluation, possibly at the end of the rotation, really gather that feedback, whether it be verbal feedback or written feedback, and then come together to really revise the learning experience. Next slide, please. And so we've had a lot of positive outcomes that have occurred. We have increased student group size that's allowed for student facilitators, so especially when students had previously participated in the ambulatory care elective or had previously been on this same rotation. They were then able to take more of a facilitator role and really understand the aspects that go into facilitating a topic discussion or facilitating a literature review. We were also able to increase the amount of faculty that contributed to this virtual rotation. And so including all of the ambulatory care faculty, we were able to expand the amount of students that were on rotation, which allowed for more collaboration. We were also able to optimize current evaluation forms. So we went from not having weekly time logs to then implementing weekly time logs to really determine how students are using their time. And with each rotation cycle, we were able to fine tune how we wanted to best evaluate the rotation we were providing. We also were able to flex in and flex out the EHR Go case as needed. When we had started this virtual rotation, really none of us were able to see patients in person. Personally, I know I was trying to determine how I was going to see patients virtually. And so we were able to really use these EHR Go cases as patient interactions to take the place of in-person interactions that patients or that students would have gained on our rotations. As the pandemic has evolved throughout the year, we've created more of a hybrid model. And so oftentimes students are able to go on site and see patients in person at least a few days a week. And so we were able to flex out those EHR Go cases when they were able to be replaced with patient interactions once again. And lastly, we were able to share the workload. So rather than myself and my 7 fellow presenters all teaching diabetes one week, all providing a topic discussion on hypertension the following week, we were really able to focus on one area and share that workload with others. And so it did free up our time and allowed us to really provide a comprehensive week, which was diabetes week, where we focused on endocrinology, or a week where we really focused on hypertension. I'm now going to turn it back over to Mary to finish out our presentation before we go into the breakout rooms.
Okay, so what we're going to be doing is, just because of the limited time, we have about 3 minutes for a breakout session and maybe 3 minutes for a debrief afterwards. So we're going to be breaking up into 4 different groups where you have a chance to ask your questions individually, share some ideas, bounce off any ideas that you might have in a way to help improve your own curriculums. And then we'll meet back up again and debrief about what we learned.